So it's a pleasure for me to welcome you to another episode of Guide Unlocked. And today I think is very unique because, first of all, we're here together with my long-term friend and colleague and research colleague, Professor Daniel Boozer. And we're like in Italy, in one of the most cultural cities in Florence. So Danny, welcome. And of course, we're going to keep this very casual. We're having like almost like a coffee, moment. And both of us know each other for like 35, almost 40 years now. And we're going to talk a little bit about the history that we went through. And one of the topics that everybody was always asking, and I asked myself, is like, we've gone through this evolution of surfaces. We've seen good ones. We've seen bad ones. I started early on with the machine surfaces. You started early on with the TPS surface.
Yeah.
So tell me, in your words, how do you see that what we went through, and where should we go for the future to prevent, complications, of course, maintain success, integration success, but prevent all these complications that we're seeing all the time, like, peri-implantitis and infection. So how do you see the old days? How do you see today?
Thank you so much, Sascha. It's a big pleasure to be here. I think we should remember what we had in the late 1980s. We had two implant surfaces, the Branemark surface with the Swedish implant, Branemark implants, and they integrated well, but they didn't have the same success rates in the maxilla. They had to use very long implants, bicortical,
I remember.
and so on, and no short implants, long implants. But big advantage, actually, very rarely an infection. Whereas the other surface from Schroeder, the ITI, was the titanium plasma sprayed, showed much better integration. But the early prototype implants had the TPS all the way up, actually supramucosally.
Okay.
And there they have seen, and I did some of these surgeries in '84. Many patients had problems to keep that clean, and they developed a mucositis, peri-implantitis. That's all. The terminology actually was established by Monvelli in April 1987, peri-implantitis. So then we tried to improve that surface, going away from this very rough surface to a micro rough.
This was around what time? Well,
yeah, the paper was published in '91, and I will say that the market shifted away from these machine surfaces in mid-90s to end of the 90s. And AAA was so very early, then of course Strab was SLA, and then the latest one, or the last one probably was Mobile Biocare was Thailand, early 2000. So that gave a lot of advantages. Shorter healing periods, shorter implants, same success rate, maxilla, mandible. But all of a sudden, this surface is a risk factor to get exposed and causes peri-implantitis. So one of the implants of Straumer was this so-called tissue-level implant, was a hybrid. And the hybrid terminology was established by Dennis Tarnow, 1993, who said, we cannot make the whole implant micro-rough, it should be smooth on top. And I think now we are moving in a direction that we're going to do a second paradigm shift, but that all implants should be hybrid. That means transcrestal, even starting in about below the crest with the machine surface, and for anchorage in the bone, micro rough. And I think that is the future solution, and it's independent of the company, because we should convince all the companies to emphasize this development and actually put,
what's interesting, if I go back a little bit of history, like, when I started, it was 86. I got exposed to a company called Stereos.
yes,
Do you remember that?
yeah, of course.
And Stereos had actually an acid-etched surface at that time. And then they had, like, I don't remember if it was a polished surface or a machine surface, but they had already also a hybrid implant.
Yeah.
Because the top of that neck was like around 1.5 millimeters or so. Machine. And then later on, of course, there when they turned to Nobel, Nobel took them over. there was a while that like the Nobel implants had like a 1.5 millimeter.
It doesn't make sense when you have a periodontal dissonance and with a defect. What are you doing? We do the root planning. We try to eliminate the roughness of the root. So therefore, we should not install implants with a roughness from beginning.
Right.
So we have to have a certain safety buffer. So I place my implants, and I mainly place implants from Straumann, as you know. See, I place these borders smooth or the machine to micro rough about a millimeter subcrestally, because you never know exactly how much remodeling you will get. But with that, you don't have the risk that you get an exposure of micro rough surfaces.
And then, okay. So then, if you think about the machine surface, right? Like, because we have to be very specific. This is a machine surface.
Yes, it's not polished.
Not polished. So that's really important.
Yeah.
If you think about the machine surface at the neck, we know, of course, from like the old days of the Branemark screw, that we would always get like, an acceptable resorption about like 1 to 2 millimeters, and everybody accepted that.
Yeah.
So are you accepting now that we're going to see bone resorption in that same range, or you think it's going to be different?
I think the amount of, let's say, bone saucerization, as we called it, because this is not bone loss due to pathology.
Right.
This is physiological. And I think it is not because of the smooth surface. It's because of the transition where the crown starts or the prosthesis. And this is the microgap. And early 2000s, they came up with this platform switching concept to eliminate this microgap, and then to go inside, and then you go up, and then the crown starts 2 millimeters further up. Then you see much less resorption.
Okay.
So therefore, I think it's the microgap issue. There were many studies that showed that from the group of San Antonio with David Cochran. They showed that when you have a microgap and then the prosthesis on top has a certain micro movement. So probably the microgap opens up and closes down, and then you get an infiltrate there, a chronic infection. And that means you cannot get there the epithelium, also the connective tissue adaptation. So then the ground growth of epithelium goes beyond this, and then the body resorbs the bone.
Yeah, to a certain level.
To a certain level, to allow the soft tissue.
Yeah, because if I go back into the old days, when every time I would open up a Branemark implant, and I had like a titanium abutment on it, and it had received kind of this like, steady state, no more progressive bone loss, steady state. But I removed the abutment, I could smell, like the
anaerobes,
chronic inflammation through anaerobic bacteria.
Yeah.
So you smell. Yeah. But now, of course, when you have these better connections, internal platform switching, you still sometimes, but not as much.
It's much better. I think that's important that the companies have made a lot of progress in manufacturing process. So they can produce much more precise connections. I know from Straumann, the products are produced in the Bernese Schüler, right? They can produce at the fidelity of about, I think, 5,000ths of a millimeter. But of an extremely precise production. And that's what I see now is that the new implant we are testing, the 4th generation, this TLX, TLC, as a new connection, new 5 years old, this torque fit. And I see now on the radiographs at 1 year and 2 years, at 3 years, even 4 years, that this bone saucerization is much less in volume, through about a millimeter. That means first, the microgap seems to be much more micro. And second, you get a bone adaptation to the smooth surface, to the shield.
Okay. So to summarize this, I think definitely we came both from a slightly different aspect, right? I came from machine, you came from the roughened, and now we're almost merging these two worlds.
Yes.
To prevent again complications, first of all, at the crestal area, at the gingival area. but also, of course, to maintain our almost like 100% integration rate of implants in a healthy patient.
Absolutely.
So, okay, let's move maybe to another topic because we want to get exposed to other things like abutments. I know we both are maybe not like the best prosthodontists because we're
no prosthodontists.
I actually was educated as a prosthodontist at the University of Aachen with a good friend, Professor Spiekerwood. So I do have a background, but like, how important is it for you and for your team, because you work at a team, the abutment and maybe, that connection and the height? Because I see in the US, a lot of technicians are putting whatever they can, on implants.
Okay, and I think we have to differentiate. When you do a tissue level prosthetics, then the crown goes to the implant shoulder. That is primarily in the posterior. And that makes a lot of sense because then the shoulder is supracrestally and you get minimal bone remodeling and then you have very stable. That's one. The other one, in the aesthetics bone, we don't do these kind of restorations. We do the vario base, or how do you call this? The
Peri-base.
Peri-base, see? And I think there I learned from our prosthodontists that these abutments should not go out like this.
Not diverge.
Not diverge very quickly, because then you lose tissue. And I hear from that we should be at least 2 millimeters in height. So going out very slim, and then 2 millimeters, and then the crown comes. And that's what we do. So actually then the crown is glued to the abutment, and then it's a screw-retained restoration.
Yeah, and just kind of to support that, like, when we work with our laboratory technicians, that's what we tell them. We tell them, okay, if we're going to go the titanium base, or tie base, or vario base, the height should be around that 2 millimeters. Of course, each company has different heights, but it should be, so I do that.
I would say at least 2 millimeters. Can also be 3 millimeters.
Right.
But 2 millimeters is a good recommendation.
Yeah. Now, to finalize our conversation, we cannot talk together without talking about regeneration.
Of course. The Chinese.
So we have a lot of things we can discuss, but I think one point where there's a lot of potential for, like, which we can maybe uncover or unlock is, I know you have a very specific idea about collagen membranes. And if I look in the marketplace, there's so many collagen membranes available today. And I feel like that our colleague, our clinician, does not know the secret of a difference of a natural collagen membrane, or we call it native collagen membrane, versus those who are on the market, like, who's supposedly longer stable. So tell us, from your perspective, what collagen membrane do you think is the right biological material?
Okay, I think also here we have to keep in mind where we came from. And so we came in the early 1990s, and there we were thinking the membrane should stay there for 6 months to allow the maturation of the healing model. And then we learned that when we use autogenous bone chips in these defects combined with a second filler, we have first a much faster bone formation underneath the membrane, and that we can shorten the healing periods significantly. So we go to most cases, when we do a simultaneous GBR, we learn to 2 months of healing. That's what I do. When it's, let's say, a sausage technique outside, then can be 3 months, but that's it. It's different when you go stage, as you do a regeneration first, then you have to wait longer. Okay, then we learned that collagen membrane is a big advantage because there is no need to remove it, so you eliminate the surgery for the patient. And I have a clear preference for non-cross-linked natural collagen membranes.
But then, like
BioGuide. BioGuide has been tested in I don't know how many animal studies, and of course now in many long-term studies clinically, and the results are excellent. So I don't need a membrane that is cross-linked that should last for 6 months, because there's no need for that. We tested one of the most of Geishlich, and we had a lot of complications. There are a lot of complications with remnants and so on. So non-cross-linked natural membranes, 2 months, they are probably at 4 weeks already gone. but underneath the tissue has formed, and this combination with composite graft with a collagen membrane for horizontal augmentation, two-wall different configuration works exceptionally.
Yeah, yeah, and I have to tell you, like, I've seen so many, of course, again, in the US, there's so many different options. And I've seen so many cases now where cross-link membranes were used. And if you look at the soft tissue that's covering like a regeneration, or like this GBR, tissues look good. But the moment you open it up, there's an inflammatory process underneath.
Yes, of course.
And so
membrane, yeah.
Basically, like, clinicians are using a collagen membrane thinking that it will do a good job. And it might do it sometimes, but it's not like biocompatible, and it's not biologically acceptable. Okay. So I think it's really important that like we make that difference in like a collagen membrane is not a collagen membrane.
We can also say GBR is not GBR. See, sometimes I hear, oh, I did a GBR and it didn't work. I said, what did you use? Yeah, just put in bios. I said, of course. That is not working as predictable as you use a combination of autologous bone and bios. We all started in the late 1990s with these composite grafts. You see how much they can really give you when you go into vertical augmentation, because there you need a lot of autogenous bone to get this osteogenic potential in there. And this is all driven by growth factors.
Yeah.
And you cannot replace these growth factors by a growth factor product you buy from a company. So that's also interesting. We learned from Bob Schenk. Bob Schenk always said, you see, the idea that the single growth factor applied at day of surgery will replace Mother Nature mechanism is complete nonsense. Because bone healing is a cascade of different steps, different involvements of different growth factors. So Mother Nature is doing the healing, and therefore when you give autogenous bone chips, the chips will give you the growth factors you need, because that's like the healing of a fracture.
Yeah,
and that's
I think this is like where a lot of clinicians, I think, make a mistake to their implant dentistry, because implant dentistry was born like a biological discipline.
Yeah.
And a lot of implant dentists think it's mechanical. And if you think about it, like, you learned like early on with Bob Schenk.
Yeah.
And if I think about myself, I learned with Carl Donut.
Yeah.
Of course, we both know each other's.
Yeah, and I did 2 studies with Carl Donut as well. Yes.
Yeah.
He was more a soft tissue guy.
Yeah. But I guess this is where, like, I think a lot of dentists need to like switch their head, is not so much think about the mechanics only, but start understanding that we're in an environment which is biological.
Absolutely.
So heavy material, think about that.
I think the basis of a good implant surgeon is that he understands the biology.
Yeah.
Because that's what you really have to focus on. And of course, we made a tremendous progress in that field. In the 1990s, I would say, Bob Schenk, coming from the orthopedic field, fracture healing, gave us really unbelievable inputs. And he was a freshly retired professor of anatomy, and he shared his whole knowledge to our young generation. And then later on, we learned from the Gothenburg group, the post-extraction alterations. Also, this is clearly driven by the genetics. You cannot stop bone-to-bone resorption. When it's a thin bone, the bone will disappear. It's just as simple as it is. No marketing guy can stop them. When they actually come out and say that they have no clue about the tissue biology. So this is my advice to all the youngsters: spend time and efforts in tissue biology, and then learn from the surgeons who have adapted their surgical techniques using these principles based on tissue biology, and that works.
Yeah. Well, I think this is like some pearls that like we're discussing. This is what we want to discuss always with our colleagues. And Danny, you're from Switzerland. Of course, I originated from Europe. Now I live in California. I think it's incredible that we can share still our experience and knowledge. I want to thank you for coming to the guide program here, especially here in Florence. We had a beautiful dinner yesterday.
Oh, we did.
And I hope that we can do many, many more. So thank you so much.
My pleasure. Thank you, Sascha.
Thank you.